Instagram here. All right, we should be going live.
I always forget I have to go live on my end.
Well, it takes a minute for Instagram to catch up.
Oh, here we go. Okay.
All right. I think I'm live on Instagram.
I think I am live on Instagram too.
Excellent. Glorious. Hello, everyone. We'll give it a minute for people to kind of tune in. That's about a minute. So I'm Dr. Brandon VanderWel. This is Dr. Mimi Tan. We are at the surgeons at Eviva. We are a weight loss office that does weight loss of all sorts: nutrition, medication, non-surgical procedures, surgical procedures, revisions, do it all. And so we're here today. We're having a live question and answer session. If you have any questions, please post them in the text box on Instagram or on YouTube. And we're happy to answer your questions. We already have a couple that have been submitted already. And we're kind of focusing on a little bit on medical weight loss today. One of our PAs, Betty Yu, she's going to be joining us in a little bit after she's done with the patient. And yeah, she does a lot of medical weight loss in our office, and just looking forward to a great conversation. So, all right. So, Dr. Tan, medical weight loss. We have, I think a good place to start is, number one, what is it? You want to kind of kick us off and educate us a little bit about what the options are medical weight loss wise.
Yeah. I mean, this is a little bit of a pivot from what we typically talk about. We're getting out of our surgery comfort zone, so to speak, I would say. And I think a couple of different things. Historically, and like we both did this, like we went to med school, we did residency, we did all this training and stuff. And historically, when someone has come up to a doctor and been like, or any provider and been like, how can I lose weight? The options are basically diet and exercise. That has been what was taught to me, at least when I was in med school: diet and exercise. You got to eat a little bit less, cut your calories, and you got to move a little bit more. And sometimes that's all that we go into. And we don't really honestly learn too much more than that, just basically in medical school. And what's really cool now, especially in the last couple of years, is this field of obesity medicine, so to speak, has really kind of grown in terms of like all the tools that we have available to us. And that's primarily these medications that we can now offer our patients. In addition to diet and exercise. Diet and exercise is always an important piece, but now we have ways to actually facilitate that and make things more effective for folks. And oftentimes it's a really nice adjunct along with surgery as well, which is, again, how we spend most of our time. Broadly speaking, we have two categories. I usually divide them into two categories. I think, you can go into mechanism of action, you can go to classes of drugs or whatever, but I think the easiest way to divide things is oral medications that usually you take every day, or you have these newer injection medications that usually you do once a week. And these newer injection medications, they're newer, they are going to be a little bit more effective. And I bet people will have more questions about the injection medications, but I think the oral medications have their place too. I have a lot of patients who really love the oral medications that they're on. They're very effective for them. And so there's pros and cons with each. So the nice thing about the medications is that there are a couple of options that we can now play with. There's probably going to be more options coming out. And so it's it's a growing field, I would say. We're learning more and more about it. So
yeah. Who's a good candidate for medical weight loss?
Who is a good candidate for medical weight loss? I think that is a very, I think that's a good question. And that's almost like a philosophical question, I would say, within the world of medicine currently, because it goes into when is weight a problem for folks? I think that's the base question. And people will look at it differently. The basic way that we can look at it is are you in an unhealthy BMI? I think that is an overly simplified way to look at this. I don't think BMI tells a very full picture at all. It's good for a large population of people, maybe doing studies, et cetera, et cetera. But when you look at one single person, BMI is not enough. And so I like to look at the whole holistic picture of my patients and see, okay, yes, you maybe have excess weight, so to speak, from a BMI standpoint, but how is that weight impacting your life? Do you have metabolic diseases that are associated with that weight? If you have metabolic diseases plus excess weight, I think absolutely there should be some intervention that we're doing. Diet and exercise is not enough in that situation, period. And do you have like physical limitations, so to speak, because of your weight? Do you have joint pain? Do you have back pain? Are you not able to be as active as you want to be because of the weight? Are you being held back by your weight to some degree? And I actually think this is the most common thing that my patients cite when I talk to them. It's like, they say, I want to be more active. I want my joints to hurt less. Like, I hear this day in and day out. And so that's a huge one. And then the last one I think is like, how does this affect you from like a psychosocial standpoint? Like, how does this affect you emotionally? Have you lived your life feeling like you don't belong because of your weight for some reason? Are you like anxious because of your weight? You feel like you can't leave the house because of your weight? These are also really important things to think about as well. And so it's a really holistic picture that you have to look at globally, I think, when it comes to who should get help for their weight. And so I think if you check any of those boxes or you say yes, like I think this is negatively impacting me, then you are a candidate for having treatment, having medical weight loss, starting a medication, so to speak.
Yeah.
Do you have anything else to add that I missed? I think this is like...
Couldn't agree more. Yeah. I mean, I had a patient the other day who was talking about how, she, had gained some weight after a pregnancy and then, didn't even want to go out with her family on their boat anymore, and like, wasn't going out with their kids and with their stuff. It was just like, man, that is like, what let's go, let's go.
Let's go.
What are we waiting for? Let's get after this. We have tools. There's good tools. And then, so I think that's a good segue into the next one, which is like, well, when should you do a procedure and when should you do a medication?
Mm-hmm. I think that's also kind of a nuanced way to look at things. And I think this is really where knowledge is super powerful for our patients, right? Like every patient who comes to me, I want them to be knowledgeable about what weight loss medications can accomplish, what they can't accomplish, what the pros are, what the cons are. And then the same for surgery as well. Generally speaking, if you have a lot of weight to lose, meaning more than like 20% of your total body weight, then probably surgery is the way to go. If you have less weight to lose, then medications are a good starting point. And at the same time, there are plenty of folks who probably benefit from both well. Yeah. So it really depends. And then it also depends on just like, what are you willing to do? Like some people are willing to have surgery. Some people are not willing to have surgery. They're not ready for something like that yet. And so having lots of options here, I think is really important. But
I think that's totally it. This conversation is very nuanced and it's very different for every person.
I also have patients who are like, I don't want another medication, period.
Yeah, absolutely.
Like, I don't want to deal with that. So and then we land on surgery. So
all the time. Yeah. Mm-hmm. And that's where I think also the endoscopic sleeve fits a nice space in between there too. Mm-hmm. The people that are like, I'm not literally looking into surgery doesn't really interest me and all of its risks, or perceived risks or concerns for like its permanency. But they're like, medication, I don't really want to be on medication my whole life either. And that's a topic we'll talk about next. But, like is there a middle ground there? That's where the endoscopic sleeve, I think, fits nicely. And it complements the medications, particularly the GLP-1 medications. It complements that really nicely.
Yeah. So. Yeah, totally.
Along that lines, like what do you see as, let's switch gears to talk specifically about the injectable medications. So like semaglutide, which is a GLP-1, tirzepatide, another GLP-1. And so that's like Ozempic, Wegovy, that's semaglutide. And then tirzepatide is like Mounjaro or Zepbound. what do you see as, like what do you kind of counsel patients that are interested in those medications? Like, what does this look like long term? What's our big picture plan here with these medications?
Yeah. Well, I have a lot of folks, who are now interested in these medications, and they're very effective medications. Long term, I mean, I think you're getting at, do we have to keep patients on these for the rest of their lives?
That is mostly what I'm doing.
Yes. That's probably that's for the most common question I think I get about these medications. So the studies that we have, and we don't have actually that many studies right now because these medications are so new, but the studies that we do have show that most folks who come off of these medications are going to regain some of their weight. And I think that, like, honestly, it speaks to this newer understanding that we have, that obesity is a chronic disease. It's like high blood pressure. It's like diabetes. And as with all of these chronic diseases, for the most part, when you come off of a medication, it's likely that your disease is going to start coming back again. It's going to start flaring up again. And I think it's kind of the same way that we should be approaching this as well. Now, I think the studies that have looked at weight recurrence after medication stoppage, I think there's a lot of more studies that we can probably do and will be coming out over the next few years in terms of, like, how quickly do we wean people off medications? Yeah. How are we doing that, et cetera, et cetera. And so there's a lot more that we need to learn. I think in practice, I try to get people off medications if we can, with the understanding that, again, you might not be successful in terms of keeping the weight off when you come off of the medications, and that's okay. That's most people. We can certainly try, or at least try to reduce the dosage of your medication. But the expectation starting out, oftentimes I set that expectation of, like, okay, a lot of folks need to stay on this long term.
Yeah. To some extent,
to some extent, yeah.
Maybe not.
It's not a guarantee.
Maybe not all the time, but usually have a dose or two in the fridge sitting there in case they need it. So that's been, I think, a little bit of our experience. Hopefully, our PA Betty Yu will be able to join us. She does doing a lot of this right now, and it's great to hear the medical weight loss team's perspective, who is really doing a lot of medical weight loss right now. It's really interesting. It's really helping a lot of people. But I think it's sort of, bariatrics is always, it's always on the edge of the Wild West of medicine, because unfortunately obesity is just not that old of a problem, but, and so we're just keep trying to stay ahead of it and keep trying to do more stuff. So we just don't have as much data on it. So, but I think, where do you think the future lies with obesity care?
Ooh. Where does the future lie with obesity care? We've talked about this a little bit.
Yeah, it's sort of a pretty loaded question. So I certainly have my thoughts.
Well, I think these medications, they're going to get better. We already know there's trials coming out now with these newer medications. They are going to get better. We're probably going to get better at having fewer side effects. Wouldn't be surprised if we had an oral medication at some point that came out that was also highly effective. Right now, the oral medications are substantially less effective than the injection medications, generally speaking. But again, I think those are going to start getting better soon too. There's a lot of, I've been listening to a lot of lectures from some medical conferences recently, and I'm like, man, there's a lot of smart people out there working on this problem. Yeah. And I'm like, wow, there's so many smart people out there. So the drugs are going to get better. But I think along with that, looking at the bigger picture of things, my hope is that, and I think we're a little bit behind this still, but it is improving. I hope that obesity becomes a medical problem that all physicians feel comfortable managing in an effective manner, and in a clinically effective manner as well. In medicine right now, we're often chasing our tails. And this is how we've done medicine for a really long time. We've had kind of a complications-centric way of treating folks, which is we wait till a disease is kind of bad enough before we start actually treating it and addressing it. And, we throw medications at it, but at that point, the cat is already out of the bag, so to speak. And a lot of these different diseases and the complications that come with the disease, oftentimes excess weight is where it starts. And we have never really gotten to the point where we're addressing that excess weight in an effective way. And my hope is that as we have more tools, more and more physicians are going to be actually addressing kind of the base issue. And then we're moving away from like the complication-centric care to more actually like prevention of problems down the road. So that is my hope. I hope it opens a lot of doors for folks. It opens conversations for patients who also have had to deal with so much stigma in their care all their lives, oftentimes. And so I hope it just starts becoming a more open conversation, a more, effective conversation for people.
Honestly, yeah. Medicine has done a very poor job of managing obesity. For the entire, like up until, still like physicians are very bad at having conversations about obesity. They're very bad about counseling patients about healthy behaviors and how to kind of get them going. But also, to be fair, those conversations are never short. They're always complicated. They're always nuanced. They're always, there's a lot of things you have to unpack with obesity. It's a very different condition than any other, medical disease that we really have to treat. And it's really hard to be, and there's a reason that doctors avoid it and they don't want to talk about it. They don't want to try to address it, is because it's so multifaceted. It's so multidimensional. And that's where I think, I think it's going to be interesting to see where we go in the future. I'm hoping that, I really want us to have a much more scientifically rigorous approach to obesity, in general. And the sense of like, remember when we were studying for our boards for surgery, you just like download all the NCCN guidelines for cancer of every single cancer. And this is very, very thorough, complicated algorithm of like, if you have this stage and you have this condition and this factor, then you do this or this or this. And then maybe from there, you go this, this, or this. And each thing's like this, it's got like a ton of branches, right?
Yeah.
And I think if we're, that's where obesity needs to go, is that we stage the disease. Like where's the position of the patient? Like what's their condition and how bad is their disease? And, then we go from there about like, okay, are they interested in a procedure? Are they interested in medication? Can we do both? Which medication should we do? If we do a medication and we get to this result, but not this result, what do we do next? And I think we just have a much more prioritized and effective and data-driven approach to this thing, to this disease. And where I honestly think where we're going to land is, for most people that have a BMI 30 and above, we do a procedure like a laparoscopic sleeve or an endoscopic sleeve, and we do medication. And that is going to, just kind of like with cancer, like we don't mess, like if someone gets breast cancer, like I had one of my endoscopic sleeve patients I saw today who's doing just fantastic, crushing it. She's 2 years ago, she had breast cancer, right? She had surgery, she had chemotherapy, she had radiation. And it's like, well, was the chemotherapy and the radiation overkill? Maybe. But the reason that you do that is because you're trying to get the best outcome for the most amount of people. And I don't, why don't we give that approach to obesity too? Like it's crazy to me that if you like, obesity is such a hard and complicated disease, and it's so multifaceted. There's so many things that go into it. Why do we not set people up for the most amount of success possible, which is like, do some sort of like offer a procedure and offer a medication. And then you say, and then offer the behavioral health stuff, offer the mental health stuff, offer the physical therapy, like the exercise therapy things, and like empower patients to really get better from this condition and to really keep moving forward and be healthier.
Yeah.
Because right now it's, I think it's going to be a really interesting time. It's a really interesting, and I think a very exciting time in taking care of people with obesity. Like I was just thinking about that patient, like the boat one, and it's just like, man, there's just in 2024, there's no reason. Like there's no reason that we can't be really aggressive about this situation. And like, let's get back to life. Let's get back to like waking up in the morning and being excited about your day and being excited about doing stuff, and not feel like you're limited by obesity at so many steps of your week. And obesity is tough, and not everything we do fixes it and fixes every single problem about it. But man, we got some good tools now. We really have some good tools now. And that's where I think in the data, like especially with the endoscopic sleeve plus a GLP-1, like getting north of like upper 20s total body weight loss percentages on average, that's like entering surgical weight loss procedure realm, with something that's so much more approachable. Risk wise is just, very approachable risk wise.
Yeah.
The key is now we just got to get people, on the endoscopic sleeve part, we got to get other, the training for it. This is just a complicated procedure to do. So,
yeah. Well, and I don't want to get too much off topic, and I don't want to get too much on my soapbox, but it's stigma. At the end of the day, this is stigma. It's obesity stigma. It's, unfortunately, it's societal stigma. It's medical, like stigma from healthcare providers.
yeah.
It is shame. Like our patients hold so much shame about being overweight or having excess weight. And there's no easy solution to that other than education, and trying to become more and more aware of this as a problem over time. Like, for your patients, like for the patients who come to us who are like, our joints hurt, our knees hurt, et cetera, there's no qualms about, there's no judgment. There's no, like, no one questions it. If they go to an orthopedic surgeon to get a knee replacement, zero. No one is ever going to say, oh, you don't need that. Oh, you don't, I don't know why you're having that, but bariatric surgery, which is going to help that base problem, everyone has a comment, right?
You show up to your OBGYN with infertility and your BMI is 35 to 45, and they're like, well, I don't know. Everything checks out. And it's like, no, it doesn't. Like weight is a very, very known cause of infertility.
And, and if you think about like someone who has diabetes, right? Diabetes with excess weight to some degree, there is currently no medicine that is going to cure you of your diabetes, period. Yeah. That diabetes is going to be a progressive disease. It's going to just, it kind of just slowly gets to you over time. The one cure that we potentially have, and not all surgery is curative, but the only potential for cure is bariatric surgery. Yeah. Yet we are not using bariatric surgery as the first thing for diabetes. And that's like a wild thing to me, because if you kind of flip that script a little bit and replace diabetes with excess weight with a cancer, if you had a cancer where surgery first could give you a cure, no one would blink an eye, right? Like no one would even like, no, exactly. Everyone would be like, that's a no-brainer right there.
And now, especially with GLP-1s, the cost of a GLP-1 or insulin, like surgery is more cost effective than those.
So we're getting into, these are the things that keep us up at night.
Oh man. Soapbox.
But anyways, should we do a little quick break for some questions?
Yeah, let's do it.
I have two that were sent in that are not related to medications, but I think are pretty interesting. Let me find them here. I have one from Ismail. I'm sorry if I'm saying your name wrong. And he says, I have a big question, ! So now that I have lost the weight, so I'm assuming Ismail's had bariatric surgery, I want to start lifting weights and start building my muscle again. What should my protein intake be, and how can I meet my protein goals when I can barely eat? With a sad face. Ismail, that's a great question. And I think this is a question that all of our patients struggle with to some degree, in terms of once you've lost the weight, the most important thing to do at that point is trying to maintain your muscle mass. At least that's my opinion, is how can we maintain your muscle mass? How can we regain the muscle mass that you've probably lost in the process of losing the weight? And protein and lifting weights is probably the two big things that you can do here. It's hard to say for either of us, I think, in terms of what your specific protein goals should be. I think most of our patients have at least a minimum of 80 to 90 grams, if not higher than that, once they're in the maintenance phase. But again, depending on how tall you are, that might change a little bit. But I think the best advice I can give here is work closely with your nutritionists and your bariatric surgeons here. There's a lot of little strategies that we can do to try to get you more protein throughout the day. You already know what the important things are here for you to start working on your muscle mass. But sometimes it's just a matter of like going through your day and figuring out where we can add a little bit more protein. And you might even be hitting your protein goals already. I often have some patients who are probably eating more protein than they need. And so it's always a little bit of a discussion, I would say.
Yes,
it's pretty personal.
It's a it's a journey, and you kind of keep working on it, and you see what works, and you pivot as necessary. So
yeah,
a couple comments here. Tide Changi, maybe. I pray to get my procedure done in October. Dr. V, thank you. You're my hero. That's nice. Thank you. And then had a couple other questions. How's my tongue heal? Not sure about that one. Arm falling off in an accident. Sorry, man. You're asking the wrong people about that one. So, yeah, I think what I find with people that do really well with like working out and stuff like that, sometimes it's just like that process thing. Keep up your exercise, keep up pushing your body, try to keep seeing improvements and gains as far as from like an actual weight standpoint and rep standpoint, making sure you're hitting your protein, making sure you're getting your hydration, watching your weight and your calorie numbers. And then honestly, just like the most important thing about this is consistency. 100%.
Yes.
Consistency is the name of the game with success in that realm, especially once you've been away out from surgery and you're like, hey man, I'd really love to put on some muscle. I really love to get stronger. I want to lose a little bit more fat. Like that's just it's gonna be the long game, and it's all about consistency. So
yeah. And I'll add, like, consistency doesn't mean that you're perfect all the time, right? Consistency means that you might have a bad day. You might have a day where you're really busy or you're stressed with whatever things. You might fall off track for a day, a couple of days, a week, a couple of weeks. But what we mean by consistency is that when you have those bad days, you get back on track and you have some system of getting yourself back on track. Whether that means touching base with your team again, like I always recommend that, so we can help you get back on track. But it's never a straight line. It's
never a straight line. Yeah. And also I think the place where consistency starts is you have a plan of what you're actually trying to be consistent in. So if it's like in the gym or like if it's working out, you're like, I want to just get to the gym for 20 to 30 minutes 3 to 4 days a week. Like that's your first goal. And then you show up and then you do some exercise and then you're like, okay, how do I make this time more useful? And then, but just like being consistent with that first, like your nutrition wise, like, okay, I'm going to come into every day with a plan about how I'm going to get my 1100 calories and my 120 grams of protein. How am I going to get these things? And if you just start with a plan, and then you can measure your consistency about how often you're able to successfully complete your plan. And you're not going to be 100%. Like that's just never going to be realistic. You're going to have some good stretches in there, hopefully. But the goal is just that you number one, you have a plan and you just try to get better and better about executing that plan. And as you progress and you move on, you keep adapting your plan to really keep moving forward and to keep climbing that next mountain. So, all right. Does this have any effect on hypothyroidism after surgery? Excellent question. That actually came up today in one of my follow-ups today, is that how often are people do they have to modify their thyroid medications after surgery?
Yeah.
And I would say that it's not, I wouldn't say it's most people have to adjust their thyroid medication, but a real number of people have to actually probably go down on their thyroid medication because their body maybe it's less mass, maybe it's less metabolism of some of the thyroid, medication or hormone from the fat. And then when there's a lot less of it, they don't need as much. But there's quite a significant amount of people, I would say it's not quite the majority, actually are able to either go down or get off of their thyroid medication. If you're already on a lot of thyroid medication, the chance of you coming off completely is pretty low. I wouldn't say I've really seen that. But if you're on like a moderate dose of thyroid medication, there's a chance I've seen people come off of it completely. And there's people that are high, I've seen them come down to a lower dose. So it's pretty interesting. Oh, hey, look, I think we have a participant waiting in the wings here.
Wow. Special guest.
Look at this. Welcome, Betty.
Hello, I'm Betty. I'm a PA at Eviva. Happy to be here.
Yeah. We were just talking about a question from the chat came up from Tai Chengi, which was, does surgery have any effect on hypothyroidism? So we were talking about that a little bit. But yeah, we were just kind of talking about all things medical weight loss. Kind of, we opined on where the future of medical weight loss might be, of this or that, or just obesity care in general. But I would love to hear, let's kind of switch gears and talk about a little bit of your experience in medical weight loss and sort of what you see. Kind of specific. Let's talk about maybe two different veins, like people that have never had a procedure before and people that have had a procedure before and when they do medical weight loss.
Yeah. So, we'll kind of start with the surgery patients.
Hey, did we introduce Betty? Sorry.
Yeah.
Did we? I'm sorry. Oh, I missed that part. Okay, I'm sorry.
It's me, Betty. Yes. So yeah, for surgery patients, it's really tough because surgery is one of many tools that we have. It's the best tool that we have for weight loss. But you need a few different tools to do a job sometimes. So medications for weight loss for surgical patients, there's a lot of different uses for them. So you could go on medications for some period of time before surgery, right? To safeguard your outcomes, to reduce risk of complications, all these things. And also when your body's actively losing weight and the medications are helping you, you just do better after surgery. It's just easier on the body, you recover easier, all these things. A lot of people say, hey, I want to do the surgery because specifically I don't want to be on medications. And that's totally okay too. But sometimes we'll see patients after surgery who say, I'm really struggling. Or they have these kind of preconceptions where they say, okay, I thought I was never going to be hungry again. Or I thought a really tiny amount of food was going to make me feel like super full. I don't feel 100% full. Or I don't, I still feel hungry now and then, which is very normal. But sometimes for some people, they struggle more with certain things, right? Some people will say, I'm just physically hungry, or, I have a history of like emotional eating, binge eating, stress eating, these types of things that, surgery helps. It helps you make better choices, but it doesn't make those better choices for you. For a lot of people who struggle with these kind of like, just like kind of eating habit issues where you kind of eat your feelings or you kind of use it to cope with other things going on in your life. I say, a combination of therapy and medications is really, really effective, regardless of whether or not you've had surgery. I think anyone who is obese, especially if you have, a comorbidity and other health issues, should do the surgery, especially if your insurance covers it. But yeah, medications, we have a few different options. There have been some.
Can you hold on 1 second, Betty? I'd love to kind of give your thoughts on particularly the coping skills part about how medication can seem to help that with people, maybe like with the food noise part or like that draw, right? That pull towards food. And you've also mentioned before too, like patients that are struggling with like even alcohol after surgery, there seems to be like some of these medications can just turn down some of that thing. Can you kind of talk a little bit about your experience when you see that stuff? And
yes.
What you've heard from patients?
Yes. So it's so interesting because, there's a lot to unpack there. So with medications, they work in a few different ways, specifically with eating, right? They help with some of the physical hunger. They help with some of that like mental hunger, or for some people like food noise, right? The chatter, the kind of like constant voice that some people have, whether it's passive or active, that kind of just gets them wanting to eat throughout the day or in specific situations when you're not physically hungry or you don't need it, right? Or they're reaching for foods that they know they don't need. And so these medications, they work on the physical and on the psychological piece of it. Some of the medications just turn down, and humans are very, very complicated. So there's a lot we don't understand about how these medications really work. But we do see that, that food noise piece, it's kind of very similar to cravings, right? Cravings for food, cravings for certain types of foods, cravings for alcohol, cravings for drugs, all these things, in a sense, are kind of similar. And so there are some medications, like one in particular that I'm thinking about that works for, it's FDA indicated for binge eating disorder. It's used for alcohol use disorder, opioid use disorder. And so, there's something there. have we fully fleshed out exactly what's going on? No, but we do know it works really well for turning down that voice. And sometimes, when you have that voice, you feel kind of like foggy or clouded. A lot of my patients who I put on these medications don't even realize that they felt this clouded until they start on the medications. And then they're like, oh my gosh, like I had no idea. I was constantly kind of like thinking about this, or I always had that
suppressing, like you're pushing that thing back to in your head. And when you're just like, oh my goodness, I'm like finally by myself.
Right. And then it's almost like,
my back.
Exactly. And then it's like, oh my gosh, like I feel more focused. I feel like I have the bandwidth now to actually think about these things. Whereas before, I have all these other things going on. I just, I can't just drink water, right? Like water is a big one that comes up. It's like for people who love to drink water, it's great. Water is very important for weight loss and for many other things. But some people struggle a lot with water, right? You would think it's easy, right? But some people are like, I cannot remember to drink water. I don't like the taste, like this and that. And that's a perfect example of, when you have more emotional and psychological bandwidth, you're like, hey, okay, well, now I have the space and time to do these things that I know I need to do and that are important for my health. And you have that extra space to do it. So water is a big one for some people, like tracking your food, all these different things, all these kind of supportive things that you can do to help you lose weight and help you get healthy. Just again, gives you space to do that. So it's really interesting. Yeah. And some people have more of that voice than others. So yeah.
The way I break it down is like surgery. We're mostly working on your gut, right? And there's a brain gut connection. And so there's always some interplay. And some people like surgery is enough. And they do fine with just the surgery. Some people have more stuff going on above their neck, basically, when it comes to food and the problems and their behaviors. And they just need a little bit of something extra, like the surgery itself isn't enough. And so the medications are really helpful there.
Exactly.
There's so much we have to learn still about.
So much. And it's such an exciting time to be here for sure. Yeah. But I mean, if there was a one-stop shop, one size fits all for obesity, then, nobody would be obese or a lot fewer people would be obese. So surgeries out there, there's medications, there's behavioral therapy, there's all these things that you can do, some more effective than others. But for most people, combination of all these things is what's going to help you the most. So
that's what we talked about too before. It was like combination therapy is probably the future. We just need more scientifically rigorous algorithms and a really clear treatment process of staging the disease of obesity and then having a clear treatment algorithm for it. But let's switch gears to patients that have not had surgery, like that haven't had a procedure, that have a normal anatomy, that are like, hey, I'm struggling with my weight. I'm really interested in medical weight loss. Like, how do you see those people doing? Like, what's their usual, like, I mean, I know that's very different, right? Because some people coming in with a BMI of 50, which is, really obese, versus a BMI of like 31, which isn't, is a long ways away from 50. Like, those are pretty different diseases. But overall, like, what's your kind of experience and when you see, because you see a lot of these patients. So.
Yeah, definitely. I'd say, like, especially with all the hype surrounding Ozempic and these medications, right? We're seeing a lot more of people being interested in medications for weight loss. And so, for people who are non-surgical for whatever reasons they have, if you're obese, if you're above BMI 30, or if you're above BMI 27 with certain medical issues, you are at risk for developing more and worse medical issues that are related to your obesity down the line. And so, I have patients that are BMI 50. I have patients that are BMI 30. I have patients who are like 25. I have patients who are like 70. So there's a wide range in all of that. And again, it's all these like, it's really interesting because everyone's so different when it comes to weight. It's like, why are they here? What's going to work the best to help them to get the weight off? How motivated are they? All these things. But really, I kind of look at it as for one, I talk to the patient and I see like, what are your goals, right? Like, are you just wanting to get to a place where you're not fighting that uphill battle constantly? Are you, you have a set weight in mind that you used to be, like 10, 20 years ago that you really want to get to? Do you want to, be able to go skiing, right? All these things. And so I take that into big consideration because, like, while humans are very numbers driven and, we look at weight a lot, it's not the whole story by any means. And so we look at, ultimately what their goals are. Medications wise, there are a number of medications that we can use for people who are non-surgical. And again, it just kind of depends on the goals. It depends on, their concerns, right? I'm worried, there's some medications like the Ozempics, right? Relatively newer on the market, and some people are very apprehensive for that reason. Other ones like stimulants, right? Like phentermine and such. Other people are like, oh, I've heard bad things about those. I really want to avoid those. And there's a lot of options. So, it's a lot of kind of talking to the patient, seeing, where you fall with that. But yeah, ultimately it comes down to what your eating habits are, right? How you got to where you are. We have a big, long conversation, kind of some of the things I mentioned earlier, like the binge eating, right? For some people, it's alcohol. I drink too much alcohol or I use it as a crutch. Other people, it's, I just snack throughout the day. Other people, it's I have so much food noise. Physical hunger, right? Some people are just physically hungrier than others. Well, I have a lot of women who are, around perimenopausal or, after menopause, and they're starting to gain weight. The things that worked for them, that kept their weight off their entire lives, are no longer working for them, right? And so there's all these different situations, and ultimately it comes down to a lot of individual factors. But yeah, I mean, usually when we're looking at medication, like starting medications, really anyone who's at risk for these medical conditions, has that excess weight, is, deconditioned, all these things like can qualify you for weight loss medications. And, they're meant to be used as a tool, right? In conjunction with all these healthy lifestyles, right? Making sure you're eating the right things, right portions, moving, drinking water, all these things. But yeah, I would say I wouldn't hesitate to start weight loss medications in people who are obese or overweight for certain patients. And, depending on where they're at, some people might need a couple different medications. Some people might just need one or just want one. Some people might be okay doing it long term and say, hey, I really, this medication's working for me. It's managing my food noise, my this and that. I feel good on it. A lot of these medications also help just with mood and with emotional stuff. And so you have less emotional eating because it's giving you that mood benefit. And so some people take it long term. They're perfectly happy to do that. They tolerate the meds well. They don't mind paying for them. Others say, hey, I really want to use these to support the other stuff that I'm doing. I don't want super fast weight loss. I want something that's sustainable long term. I want to be off these medications eventually. Don't want to be on them forever. And so, it's one of those things. You don't have to be on them forever, but it depends on how significant all those other underlying things are, right? The emotional stuff, the psychological stuff. And when we get to that point, yeah.
I think that was a good that's kind of an interesting idea I'd like to maybe talk a little bit more about is when someone kind of gets to their weight loss goal that they have, like, what is that conversation like of like, hey, do you want to keep this drug as it is? Do you want to try to wean off? Like, and how, and if people do try to wean off, like how successful are they usually able to do that?
Yes. So, it's a great kind of a point for sure. So once we get to a goal, whatever those goals are, right, we establish them in detail. Usually we'll talk about, tapering down. Some patients are very proactive. They're like, hey, I really like this medication. Like I said, like I'm fine to continue it. I say, okay, let's maybe either switch to an as needed basis for taking the medication if it's an oral medication, or figure out, depending on what their goals are. But, other patients, vast majority of my patients, they're like, hey, let's start weaning down. What is that going to look like for me? And so I'll look at their individual kind of like challenges, the behavioral stuff that they have going on. And we'll say, okay, let's cut back. Let's maybe cut this in half, or maybe let's reduce this so that, we're not taking it every day. Or let's maybe cut down on this one medication and keep this other medication as is. Whatever that looks like, we'll slowly wean you off of it. And then we watch you really closely. We don't just take you off and throw you to the wolves. We watch and make sure, hey, are you starting to regain some weight? Are you able to maintain this weight? Is your appetite coming back a lot? Are you noticing a lot more of the like grazing, the emotional eating and such? And so if it comes to that point, I make sure that they have all the other tools that they need, right? If they do have a lot of emotional eating, I make sure that they have they either have a therapist or that's in the works, or they're on, other medication to help control, their anxiety, depression, whatever it may be that's contributing to their eating behaviors. I make sure that they're set up like socially, right? Like, are they, do they live alone, right? Is meal prep an issue for them? Like, and if so, like, let's talk through that. Like, what can we do to make sure that you are able to eat the right things, that you're not ordering Uber Eats every day, that, you feel like you can still maintain all these things, even though you live alone. And so all these things, again, everyone's different. But what it looks like is really, we just keep a close eye on you. We slowly take you off the medications. The ones that are the most effective for you, we'll probably keep you on those a little bit longer. But yeah, it's another great point to say, hey, so we've had this good weight loss. We've safeguarded it. What do you want it to look like moving forward? Like, do you want to maintain your weight exactly as is, right? Are you okay with a little buffer range? Like, are you okay with plus or minus like 5 to 10 pounds, right? And if so, I'm even more liberal in taking you off the medication, right? So yeah, I guess I feel like this is the answer for everything, but it varies. It depends.
Well, I think that really highlights an important part of obesity care in general, which is that it needs to be comprehensive and it needs to be individualized, because everyone's a little bit different, and the things that people struggle with are different, and the things that they struggle with now are different than what they're going to struggle with in the future. And so that's where I think having a team of people, honestly, that are experienced in taking care of patients that are struggling with their weight and any of the number of things there, that have a lot of resources, and not just like a, hey, give me my drug, sort of setup. Mm-hmm. Sometimes people get to that phase where they're like, hey, we are at cruise control and we are at altitude and we are cooking. And it's like, awesome, great. We're here for you. We're right there on board. But Dr. Tan, you saw that paper, right? Can you talk about that paper, that semaglutide and versus tirzepatide paper, the Providence paper, that they did with a big multi, like tens of thousands of patients, and like the weight loss was like, not that great at least for.
Yeah, it's an interesting paper because so a lot of the papers that have come out, maybe in the last 2 or 3 years, have looked at the injection medication, when we're talking about the injection medications, but the injection medications in kind of like ideal settings, which is along with like intensive dietary guidelines, exercise guidelines, a lot of like follow-up as well. And in ideal situations, we're seeing really, really good weight loss. But then in real life settings, which is this newer paper that came out recently, the weight loss is a little bit less. And so that's kind of true for most medications in kind of more real life settings. There are people who are going to kind of fall off from follow-up, who aren't going to continue the medication for X, Y,
or they're getting the medication from like someone that's like, hey, I'm going to try to just do this medication, but I don't really know how to have the conversations about your diet. I don't know the conversations about the emotional pieces and the others. Like, there's so many things that go in the troubleshooting of when it's not quite working right, or maybe we need to add something else. So
this is, we see this with surgery too, right? The implementation is absolutely key. It's not just the surgery. Like, you can do a technically perfect surgery and your patient can still do not well because they don't have the right follow-up, the right support after surgery or before surgery. Mm-hmm. And so it's the same thing with the medications. You can have a highly effective like chemical, but if you don't have the right support, the right kind of, you're not addressing the right things, as Betty said, the base reasons why folks are not losing weight or gaining weight, then it's not going to do much for you. So that's why it's so complicated. And it probably is one of the ways we might go a little sideways in terms of implementing these medications, because there is so much need and /want/demand for these medications. There are a lot of folks who are kind of giving it as like this easy button that you just like prescribe. That's it. There's no other follow-up, no follow-through. And that's probably a little short-sighted. You know, we saw that with the lap band, right? I feel like the implementation, part of the reason why the lap band isn't really done these days is because the implementation was not very good. There's other problems too, but it's truly, it requires a comprehensive
approach.
Care.
Because I think in that Providence paper, right, like with 10,000 plus patients, semaglutide's average weight loss, total body weight loss, was 8%.
Yeah.
And 8% is like something, but it's definitely not like $1,300 a month something.
Yeah.
You know?
Yeah. And so,
and even tirzepatide was like 15%, right? I mean, which is twice as good as semaglutide, but still like 15% is, you know, I think anyone who signs up for Mounjaro is really hoping for better than 15% weight loss.
Sure. Yeah. And that's the difference between maybe like having someone who, like a program that really knows what they're doing and supporting their patients. Like that's where you see those like 20% numbers. It's not, you know, some of the other ways that people are getting hold of these medications.
Yeah. Well, I know. I mean, I have family members that are in primary care and they're just like, man, I get every single day, I have multiple people asking me for these drugs. And I think every single primary care doctor is getting that having to have that conversation every day, and they're getting their toe into it. And honestly, I think this is a medical issue. Like we're just decades behind where we need to be from a medical understanding and treatment therapy of obesity, that it's just going to take us a long time to get everybody up to speed.
Yeah.
So
yeah.
And honestly, it's not for everybody either. Like, I mean, just think about bariatric surgery. Like the bariatric surgery parts, there's lots of different complicated surgeries in the world. Bariatric surgery sometimes is one of them, but it's all the other pieces of bariatric surgery. It's all the hand holding. It's all the whole person care and some emotional support and the behavioral counseling and coaching and stuff like that we love as bariatric surgeons, that honestly, we're a pretty rare breed. Most surgeons hate that. They just want to do the surgery and say, hey, are your incisions fine? Goodbye, you know? So.
Yeah. But, you know, and I think that's fine, right? That's why specialties exist in medicine.
Yeah.
Because everyone has their focus.
And everyone has their gifts and their strengths. So the hard part is that there's like 42% of this country is obese or more. And we just need as many people to be able to take care of this disease as possible. So
we have a long ways to go here.
Yeah.
I think it's an exciting time. I think a lot of
it is. It's a very exciting time.
Good is going to come over the next years.
Yes.
Betty, I know we're kind of running out of time here. One last question, I guess, for everybody is when should people do medication and when should they do a procedure?
Yeah, that is a great question. I am probably a little biased, but I truly believe, weight loss surgery is the most effective and longest lasting, I guess I should say, most protective for your results treatment out there for obesity and for other things too, actually. But I would say, yeah, if you qualify for surgery, you have benefits for it. And 100%, I think if you want to live a longer life and a healthier life, you should do the surgery. Complication rates are really low. It's a very safe surgery. And, it's life-changing. So that's just my personal opinion. But, a procedure versus medications, I mean, I think go all in, like do medications and surgery if you qualify for both.
Yeah.
Because ultimately, the longer you wait, the longer you wait, the more history you have at that higher dangerous weight, the harder it's going to be for you to lose weight. The more frustrated you are, the longer these habits are more ingrained, and the harder they are to reverse them when you do get to the point where you're like, okay, something happens, right? You injure yourself, or hey, I need a knee replacement. I weigh too much, and these sorts of things, right? Like when you're young, you don't really think about these things that much, but the weight wears on you after time. And I think we have such good tools now. Like, I agree, we are decades behind where we should be, but we still have really great treatments right now. And so I feel like, it's like,
we just got to accept where we are and commit to getting better. So,
exactly.
Tara says says a nice thing for us all, said, you are all absolutely amazing. God bless you all. Thank you, Tara.
Thank you, Tara.
So cool. Dr. Tan, what do you think?
Right.
Medicine, surgery?
No.
What do you say?
I think there's room for both. The more tools that we have to address a really complicated problem, the better, right? Yeah. But I will say, like, one of the common things we hear from our patients is, I wish I got this done sooner, right? Yeah. The other day I was seeing,
I've already heard it multiple times today.
Exactly.
Today.
It's, and I hear this from my young patients sometimes who are, have excess weight, but maybe they don't have like a metabolic diagnosed disease yet, so to speak. And they're like, is this too much right now? Like, am I kind of jumping the gun here? This seems like a lot to do for something that isn't a problem yet. And the way to look at that is, like, we are preventing problems down the road here. This is truly prevention. And the earlier that we get on some of these things, the better. And so I think if you have any question in your mind at all, whether or not a procedure or a medication can help you, you should talk to a provider who can 100%. Help you. And if they cannot help you, know that there are providers out there that can help you. And so there's a lot that we can do these days.
Yes.
It's no longer a helpless, hopeless problem.
Yes. Absolutely. Yep. Great things ahead, team. Thank you, everyone, for tuning in. Really appreciate everyone's
Thank you, Betty.
And thank you, Betty, for coming.
Thank you, guys. Yeah, it was awesome. I had fun.
Yeah, no, it's good. We'll definitely do more of these. In the future, I'd really like to get some patients on. I've been talking to some patients who want to kind of join and just be available for some question and answer. So, which I think would be really cool. So,
yeah.
Awesome. All right. Thank you, everybody, and have a great day.
Right.